We are going to talk here about a very important aspect related to the prescription of medications for ADHD, their possible side effects, and how they can be managed. As with all medications and some non-pharmacological interventions, side effects can and do occur with medications for ADHD. I believe that there must be a balance in how we consider the side effects of medications. On the one hand, if side effects are overlooked, these may result in individuals with ADHD being exposed to harm. On the other hand, if the potential side effects are overestimated, this may result in individuals with ADHD not benefiting from effective medications. In the latter case, limiting children's access to effective treatment for ADHD could have serious implications, given the substantial risks of not treating ADHD. It is important to appreciate that in the majority of the cases, although not in every case, side effects can be successfully managed so that individuals with ADHD can keep on benefiting from ADHD medications. I would like to highlight that it is crucial to assess in a comprehensive way the main body systems and functions, for instance, appetite, weight, blood pressure, and so on and so forth, at the baseline before starting treatment, to avoid ascribing to medications alterations that were present before starting the treatment. We will discuss now the most common side effects of ADHD medications and how they can be managed. Let's start with decreased appetite. Both stimulants and atomoxetine may be associated with a decreased appetite, at least in the short term. There is also evidence on delays in growth. Stimulant use in children with ADHD can reduce growth in height by as much as 1 centimeter roughly per year during the first 3 years of treatment. After treatment with atomoxetine for 2 years, height has been found to be approximately 3 centimeters less than expected. In a study lasting 16 years, those receiving treatment with stimulants on at least 50% of the days were on average 4 centimeters shorter than those receiving treatment on less than 50% of the days. However, importantly, studies have shown that several months after discontinuation of treatment, adult weight was not affected. To manage decreased appetite and possible issues with growth, the European ADHD Guidelines Group recommends the following. First, monitoring appetite, weight, height, and body mass index, BMI, every 6 months. Second, differentiating between pre-treatment eating problems and medication-induced eating problems. Third, giving medications after meals rather than before. Fourth, encouraging the use of high calorific snacks and late evening meals. Fifth, possible further options include strategies such as reducing the dose or switching to an alternative class of formulation, discontinuing medication on weekends to prevent weight loss or longer drug holidays, to allow for catch-up or growth. Sixth, referring to pediatric endocrinologists or growth specialists if height and weight values are below critical threshold that you see here in the figure. So to summarize, height 1.5 standard deviations below the average of mother's and father's height, or height 2 standard deviation below the population mean plus 1 year height velocity 1 standard deviation below the mean, or 1 year decrease of 0.5 standard deviation below the mean, or 1 year height velocity 2 standard deviation below the mean, or a 2 year height velocity 1.5 standard deviation below the mean. And just as a reminder, 2 standard deviation is equal roughly to the 3rd percentile. In terms of cardiovascular effects, in the short term, stimulants can increase heart rate on average around 5 beats per minute, and blood pressure on average around 1-2 millimeters of mercury. No significant changes in electrocardiographic parameters, however, have been reported. Importantly, there is no evidence of a significant association between pharmacological treatment for ADHD and sudden death, stroke, myocardial infarction, or death from any cause. This other figure shows the suggested management of patients who present with high blood pressure or heart rate values during treatment with stimulants. If a patient has high blood pressure, higher than the 95th percentile, measured with an age-appropriate cuff, or heart rate higher than 110 after 3 repeated measures, the options are either to decrease the dose and check if blood pressure or heart rate are still high, or refer to a specialist who will conduct a series of exams to check if the patient presents with a pathological hypertension. If this is the case, once the hypertension has been treated, ADHD medications can be resumed. Let's talk about sleep disturbance. It may be associated with the use of stimulants, in particular long-acting formulations. However, some ADHD drugs, for instance atomoxetine or guanfacine, can actually induce somnolence. As ADHD itself, with comorbid disorders, for example anxiety or depression, may be associated with sleep problems, it is important to screen for possible sleep disturbance at baseline before starting treatment. If a patient develops sleep problems, in particular delay in sleep onset, following a treatment with stimulants, possible options to manage this include: first, simply monitoring. Sleep disturbance may be transitory and get better over time. Second, implement sleep hygiene. Third, if behavioral measures are insufficient and it is not convenient to stop medication, review the possible causes of sleep problems, including treating specific sleep disorders if present, such as restless leg syndrome, or managing the rebound effect with psychostimulants. This happens when the levels of the drug drop during the day, especially with short or intermediate acting formulations, and as a consequence, the symptoms of ADHD increase. In this case, it is recommended to add small doses of short-acting psychostimulants in the evening. Or, if psychostimulant is the current treatment, consider reducing the dose. Alternative classes or formulations of psychostimulants, or atomoxetine or guanfacine. And finally, consider adding melatonin. Let's talk about tics. It should be clear that there is no evidence that at the group level, stimulants are associated with a significant increase in the risk of tics. But methylphenidate and amphetamines may worsen tics in particular subjects. By contrast, atomoxetine and possibly guanfacine may significantly improve comorbid tic symptoms. The management of tics should include the following. First, observation of the intensity of tics over a 3-month period before any decision regarding ADHD treatment. Indeed, when a patient starts a treatment with an ADHD medication, they do so usually in a stressful period of their life, in a period of crisis, which itself can increase the severity of tics, rather than tics being directly caused by stimulants. It is important, therefore, to monitor the severity of tics to make sure that we don't automatically think that they are caused by the stimulants. The second option is a dose reduction. The third is a substitution with another type of stimulant. Fourth option, if the previous measures are not effective, an alpha-2 agonist or low doses of an antipsychotic could be added, with a preference for an alpha-2 agonist as it is associated with a better tolerability profile.